Hello and welcome to Persyst Grand Rounds, an online series of lectures hosted by Persyst, covering topics related to advanced EEG analysis for improving outcomes in both neurocritical care and epilepsy monitoring environments. My name is Marie Terrell, and I am the Director of Product Management with Persyst, here to introduce our speaker and topic for today's Persyst Grand Rounds. Next slide, please. Through our customers, we understand the importance of investing in the EEG community through education, where expertise and knowledge can grow towards the utilization and implementation of EEG and quantitative EEG. The goal of Persyst Grand Rounds is to provide a platform for those with clinical expertise on topics of advanced EEG analysis as a way to connect with a broader community to share their expertise and knowledge so that we can all learn and grow together. Each online lecture features an experienced epileptologist or neurophysiologist presenting on a topic of their choice as it relates to EEG monitoring and analysis. You can visit persyst.com/grandrounds to have a look at the schedule. Next slide. So the opinions and viewpoints of each speaker are solely their own and do not represent Persyst or any other commercial entity or commercial interest. Speakers are not required to include Persyst, its software, products, or services. The content presented was not prepared or edited by Persyst. Persyst is not providing any form of compensation. And finally, what you all have been waiting for. There will be time for questions after the talk. Please write your questions in the Q&A area. There is a button at the bottom of your screen. And please do note that there is a chat and a Q&A. Usually the chat is turned off. You are more likely to get your question answered if you type it in the QA. So thank you for that. We are recording, and a recording of this webinar will be made available to everyone afterwards, to all participants. And without further ado, Dr. Benedetti is an assistant professor of child neurology at Seattle Children's Hospital and the University of Washington, where she is the Pediatric Neurocritical Care Fellowship Program Director. In the fall of this year, 2022, she will assume a new position at the C.S. Mott Children's Hospital at the University of Michigan as the Director of the Pediatric Neurocritical Care and Inpatient Neurology Program. She attended medical school at the Ohio State University Medical Center, completed training in child neurology at the University of Michigan, followed by a fellowship in pediatric neurocritical care at Northwestern University Feinberg School of Medicine's Ann and Robert H. Lurie Children's Hospital and epilepsy at the University of Michigan. Research interests include non-invasive neuromonitoring in the ICU, with particular focus on ICU EEG and quantitative EEG. She is the co-founder of the Pediatric Quantitative EEG Strategic Task Force, which is a multi-center collaborative work group aimed at improving acute brain-directed care of critically ill children through the use of quantitative EEG and expanding education of this exciting bedside tool. Dr. Giulia Benedetti will be speaking today on the clinical applications of quantitative EEG in the pediatric ICU. It is something of a part 2 talk following Dr. Sansevier's talk last month, but it is also a standalone talk in and of itself. You do not need to have seen last month's talk in order to greatly benefit from the talk today. And so with that, I will hand it over to you, Dr. Benedetti. Thank you so much.
Thank you so much, Marie, and to Persyst for giving me the opportunity to talk today. I have no financial disclosures. I will note that there are limited publications of quantitative EEG in pediatric critical care. So when there's data to cite, I will cite it. When it's preliminary work that has not yet been under the peer review process, I will point that out. And partly for that reason, a lot of this talk is going to be example-based or case-based to kind of show how I'm using it in day-to-day care in pediatric neurocritical care. So Dr. Sansevier covered part 1, and just to review what he talked about, he went over seizure detection with quantitative EEG, focal cerebral injury detection in the ICU, and patterns of increased intracranial pressure. Next, or in August 29th, Dr. Casassa will cover seizure detection on quantitative EEG. It looks like a really exciting talk, and it will have a focus also on teaching non-neurophysiologists how to detect seizures. And so I'll kind of steer clear of that because that sounds like it's going to be a really fantastic talk. So what I will go over is understanding the current landscape of how we're using quantitative EEG in the ICU, integrating quantitative EEG into managing ictal emergencies. And so again, kind of steering clear of seizure detection, but more how I'm using quantitative EEG to guide things like refractory status epilepticus, and then talk about different quantitative EEG encephalopathy patterns. So I happen to be in possession of the results of a survey from PedQuest that asked providers how they are using quantitative EEG in the pediatric ICU. So I wanted to go over what our current landscape is. So it was a survey sent out from November to February of this last year to the Pediatric Neurocritical Care Research Group and Pediatric Status Epilepticus Research Group, and then all Canadian PICUs. And I allowed respondents from multiple institutions, in part because I knew there's a lot of variation in how we're using quantitative EEG across different centers, but also even within an institution. It's often the people who are most comfortable with it who use it, but there can be a lot of variability within an institution. So I wanted to see if we got multiple answers, if that was the case. And it turned out there was a lot of discrepancy in the way people answered from the same institution. We had a nice variety of respondents of different specialties, from epileptologists to intensivists. Most were academicians. When we looked at who was using quantitative EEG versus who wasn't, we found that centers with a higher volume of ICU admissions and more neurology consults tended to use quantitative EEG more. And going along with that, those centers that had a neurocritical care service were more likely to use quantitative EEG. And then the centers that had more continuous EEGs running per day in their ICUs, so if they had more than 4 per day, they were more likely to use quantitative EEG. And I think in part that speaks to the fact that we have large amounts of EEG data every day for these patients, and quantitative EEG really serves to help us condense that data and look at the bigger picture, and it can really improve efficiency in our ICU EEG review. This is a summary of the different protocols that centers that are using quantitative EEG have, and it's comparing the continuous EEG protocols to the quantitative EEG protocols, which are in orange, and they parallel each other nicely. The most common protocols for quantitative EEG were things like status epilepticus, so again, that seizure detection and help with management. And then different encephalopathies, like after hypoxic ischemic injury, neonatal asphyxia, and then acute liver failure was another common one. These were the most popular trends that people are using. Amplitude integrated EEG is, of course, the most commonly used, and that's probably been in practice the longest and the most historic trend. These other ones were the ones that respondents found to be really helpful. And this is what I'm going to use to kind of frame the talk in terms of which trends I'll go over after we review the survey results. So these are how people are using quantitative EEG, the different clinical scenarios. Seizure detection and assessing response to seizure medicines is the #1 use of quantitative EEG, but there's a good proportion that are also using it for background assessment and assessment of state cycling and decline or improvement. This is just to point out some of those discrepancies. While 41% of respondents said that they display the quantitative EEG at bedside in the ICU, another 41% were unsure, said it was variable. So again, just speaking to variability within institutions. And then there's a lack of reviewing and reporting standards, unlike what we have for continuous EEG. So only 14% said it was pretty standard if a qEEG was running to have a neurophysiologist review it, and only one center routinely documented it in the electronic health record. So this is a potential area where we can help standardize quantitative EEG use, review, and reporting. So in summary, quantitative EEG use is increasing. More than half of the center surveys are using it, and the vast majority of people who use it find it very helpful in their care of patients. The higher volume centers are more likely to use it. These were the most popular trends. These are the most popular indications, and we have work to go on standardizing, and I think this field is very ripe for research and validation of this tool. So to kind of frame the talk, I thought it'd be helpful to talk about what our pediatric neurocritical care population is. And this is a study that came out just this year from a multi-center database of PICU admissions looking at their neurologic diagnoses. And this is just 1 year of data from 2016, almost 100,000 admissions, about 15% had a neurocritical care diagnosis, and there were well over 5,000 EEGs that were run. So this table of the common neurologic diagnoses, I think, is really helpful to think about why quantitative EEG and EEG in general would be helpful in this population. So seizure disorder was the most common. And so, of course, using quantitative EEG to detect seizures is really important. But if you think about these other diagnoses like traumatic brain injury, stroke, infectious diseases like meningitis, there's a lot of risk after the initial insult for secondary brain injury, either new insult or a secondary phase of brain injury. So if you take just stroke as an example, you have that initial blockage of blood flow, infarct core, and there are cells that have died, but then there's the penumbra around it, which are the injured cells, but you have the chance to potentially help those and save them. And that secondary phase of injury, you're at risk for things like reperfusion injury, free radical production, mitochondrial dysfunction, going down the pathway of programmed cell death. And a lot of our neuroprotective parameters are designed to help in that secondary phase of injury. And that secondary phase of injury can often occur on the order of hours to days. And so that second by second review of the raw EEG is not always as helpful as looking at the quantitative EEG, where you can really condense things and look at trends over hours for these complications of neurologic injury. And so again, that's things like stroke or delayed cerebral ischemia, cytotoxic edema, disorders of consciousness that go along with things like cardiac arrest. So moving on to our trends and how we're using them, we're going to do a rapid review of how these trends are built from the raw EEG, just to kind of frame the discussion. So I like to break it down by the amplitude-based trends and the frequency-based trends. So the amplitude-based trends are the ones that describe how the EEG waveform vary over time. So our amplitude integrated EEG, or AEG, is again the one that we've been using the longest. It's often applied in neonates, so this is a neonatal example. And traditionally it used P3, P4 electrodes, sometimes C3, C4. Persyst does a nice job of using multiple electrodes from both hemispheres, and they plot the left hemisphere in blue and the right hemisphere in red. And that's a common color scheme on the trends that we're going to look at. And you can remember the right hemisphere and red both start with R. You can plot the trends over time, condensed over a long period, and then you have amplitude on a logarithmic scale on the y-axis. And the way this works is you take a specific epoch of time, like 1 second here, and you plot the minimum amplitude and the maximum amplitude in that epoch. And you plot it as a vertical line with the minimum maximum. And then you go to the next second and you plot the minimum and maximum. And you get this stack of thousands of little bars of minimum and maximum. And what you can see during this period of abnormal quiet sleep in a neonate where the background is discontinuous, you have a really wide bar in the graph because you have a very low minimum during these periods of suppression and a very high maximum during the bursts. So let's look at when this graph tightens up. This is when the baby's awake. You have some muscle artifact, it's a continuous background, and you no longer have these wide variations in amplitude. So the minimum is higher, and then the maximum is lower, and it's a tighter graph. And you can see in this is a 4-hour AEG graph. This baby has cycled through quiet sleep, wakefulness, quiet sleep, wakefulness a couple times, and that's a reassuring pattern to see. So to go through the other trends, I want to do it through the lens of what a seizure would look like on quantitative EEG, just to help kind of solidify the concepts. And so this is an example. At Seattle Children's, we do right over left, which is not as traditional as how people typically view EEGs. So this is a bipolar montage, right hemisphere over left hemisphere. This is a seizure starting over the right hemisphere. You can see there's at onset rhythmic delta activity, slower activity, but there's overriding fast. And then the waveforms get faster and they get higher amplitude. And then at offset, you're going to get slow 1 Hertz rhythmic discharges and offset. So for an amplitude integrated EEG, This is, again, an amplitude-based trend. You get a sudden, really significant increase in amplitude. So during a seizure, you're going to get this classic arch appearance. The amplitude is highest on the right hemisphere, so you know this is a right hemispheric seizure if you compare the two hemispheres. The envelope trend is another amplitude-based trend. You pass the EEG signal through a bandpass filter, usually 2 to 20 hertz, to get rid of the typical artifact. And then you plot a running average of the maximum amplitude of the EEG waveform. And Persyst divides it nicely into left hemisphere, right hemisphere. And so during a seizure, again, the amplitudes increase significantly. You'll get a big peak in your envelope trend. And while this seizure did affect the left hemisphere, it was driven by the right, and it has that higher amplitude, and it separates it out really nicely for localizing. The suppression ratio is the last amplitude-based trend we'll go over, and it basically describes the percent of time the EEG is spending suppressed below a certain threshold, usually 3 to 5 microvolts, and a running average is calculated and displayed over time. So this is an oversimplified example, but this is an 8-second page of EEG with burst suppression. You have 1, 2, 3, 4, 5 seconds of suppression, which is about a 62% suppression ratio. During a seizure, there's no suppression going on, so your suppression ratio is 0, but sometimes post-ictally, you get post-ictal suppression, and that can be greater over the hemisphere that was seizing. And so in this right-sided seizure example, the suppression is greater over the right hemisphere, so that's just another tool to help you kind of localize where things were happening. The fast Fourier transform spectrogram is a concept that was beautifully described by Dr. Sue Herman in her Persyst grand rounds, and so I would direct everyone to that talk. It was the best description I've seen of it. But just to kind of review, passing the EEG signal through fast Fourier transform basically allows it to be represented as a weighted sum of the sine and cosine waves by each different frequency. It's basically the area under the amplitude curve. And so this is an example that just shows if you have a mechanical 3 hertz wave, you pass it through FFT, you get a peak of power at 3 hertz. You can do it for 8 hertz, get a peak at 8 hertz, and so forth. You can combine all of these frequencies, and that's looking more like our typical EEG signal, which to an untrained eye might look like kind of squiggly gibberish. But if you pass it through FFT, you don't need to be a neurophysiologist to see that there are frequency peaks at 3, 8, 12, 30 hertz. And that's much easier for our human eyes to see. And this, you can add a color spectrogram to represent power. So this is showing kind of the importance of amplitude, because this is an area under the curve trend. You can have low amplitude fast frequencies and really high amplitude slow frequencies, which is often what we see in our encephalopathic patients. If you plot the power, that lower frequency has a much higher power compared to that low amplitude fast frequency. You can turn the graph on its side and put frequency on the y-axis, time on the x-axis, and then your power spectrogram, where the warm colors represent really high power and the cooler teal color represents lower power. And the way this looks when we graph it out from a real EEG is this kind of variation, where again, the warmer colors represent higher power. So time on the x-axis, frequencies on the y-axis, our power spectrogram here. During a seizure, as we saw in that raw EEG example of a seizure, you get a sudden increase in high amplitude rhythmic activity, starting with delta and then getting faster. But you also get this overriding fast activity, so that causes some of this yellow-green coloring in the fast frequencies. This is classically described as a solid flame appearance, and you can kind of see why. The rhythmicity spectrogram is another trend that Persyst offers, and basically the more rhythmic EEG is, the denser blue it will show up. And so a seizure by definition has a lot of rhythmicity. So during this right-sided seizure, it got really densely dark blue. The asymmetry spectrogram is all about the balance of power between the hemispheres. And so when it shows up as white, there's perfect symmetry between the hemispheres. When it shows up as blue, the left hemisphere has more power. So in this example, the left hemisphere has a lot more of the low frequencies, the delta. And then the right hemisphere has greater power in the faster frequencies. The asymmetry index will trend positive when the right hemisphere has more power, and trend negative when the left hemisphere has more power. And Persyst will break it up by low frequencies and faster frequencies. So during a seizure, again, a right-sided seizure, you're going to turn really red because the right hemisphere has a lot more power. On your asymmetry index, the right hemisphere will turn, the graph will trend positive for the right hemisphere power increasing. And then post-ictally, when there's suppression over that hemisphere, the left hemisphere really takes over it. So you get a negative trend on the graph. Persyst will also break down the EEG by different frequency bands. So this is left-right hemisphere of delta frequencies in blue, then theta, alpha, beta. And in doing so, you can also do ratios. Dr. Herman also talks about the alpha delta ratio, which is something we commonly use to detect ischemia. And I'll talk about that a little bit more later, but it's, as the name implies, the ratio of faster alpha to slower delta. And things that are going to make this trend go down are things that decrease your fast frequencies, or alpha, or things that are increasing delta on the denominator. So the alpha delta ratio during this seizure example, because you're getting all this overriding fast frequency, the alpha delta ratio actually went up. And you can see again, it's the right hemisphere that's leading on that. Okay, so those are our trend reviews. Now we're going to go into actual examples of how I'm using this and focusing on ictal emergencies first. So that's things like recurrent seizures and refractory and super refractory status epilepticus. So this example is a 9-year-old with a hemorrhagic tumor in the left hemisphere. And you can see on the baseline EEG that there's a lot of asymmetry to start with. The right hemisphere has a nice mixture of complex frequencies. The left hemisphere is far more simplified. It's a lot of high amplitude delta. He started having seizures coming from the left central parietal region. So those are the seizures. They pick up very nicely on our quantitative EEG. You can see this kind of flame-like appearance on our FFT spectrogram. Rhythmicity increases in that left hemisphere. You get a little bit of asymmetry change, and you get that arc on the left hemisphere EEG. The alpha delta ratio picked it up really nicely too. So again, this is right hemisphere in red, left hemisphere in blue, and you get a really nice peak with every seizure for the left hemisphere. So now that I've confirmed that the seizure shows up on the quantitative EEG, I like to condense it. And this is a 12-hour view of his EEG. And then I will often just plot out what medicines they've been given. So we tried levetiracetam after he had 2 seizures, and it helped for a few hours, but then they came back, and they came back quite frequently. So we tried lacosamide, and you can see that then more than 6 hours later, no seizures. It worked really well for him. So then I know the sodium channel action is probably the one that's going to work for him. I also use the suppression ratio to titrate to burst suppression. So this was a little boy who came in refractory status, and we put him into burst suppression with pentobarbital. Each arrow represents a load of pentobarbital and an increase to the infusion. And so you can see with this first load, you get a little bit of suppression, but then he metabolizes it out. You load again, he metabolizes. By the 3rd dose, he starts to reach steady state, but it's not quite the degree of suppression that I wanted. So I keep loading, and then eventually we get to close to this 50% suppression. And you can imagine in the middle of the night, it'd be really helpful. You can just pull up a single page and see where your patient is at on their suppression ratio. And as long as they're staying around there, that's great. If you see that they're starting to metabolize it out, you can call your PICU, tell them to get ready to give more pentobarbital. And this is something that if you are teaching your bedside providers quantitative EEG, that they could learn to interpret as well. A little bit on the ictal interictal continuum, which is sometimes the bane of ICU EEG readers' existence. Basically, this continuum describes a pattern that has the potential to be ictal, and it's an electrographic pattern of really abnormal discharges. So it's things like generalized periodic discharges at 1 to 2.5 hertz frequency. So not quite meeting criteria for an electrographic seizure, but if these patterns had a clinical correlate, they would be considered ictal. So things like causing altered mental status or a myoclonic jerk with every discharge. But a lot of our patients are very heavily sedated and sometimes even paralyzed, so we don't always have the luxury of a clinical correlate. And so this ictal interictal continuum can be a challenge. So this was a study that came out just this month, I believe, looking at quantitative EEG to assess seizure burden and seizure assessment in superrefractory status epilepticus. And I want to take a little detour to talk about why seizure burden is so important in our ICU population, because I think this study adds some really important information that's going to help our management of these patients. So in 2021, the American Clinical Neurophysiology Society put out updated critical care EEG terminology. And one of the changes that they made was they changed the definition of electrographic status epilepticus from more than 50% of a 1 hour period to more than 20%, which is a pretty big difference to define status epilepticus. And that was largely based on one pediatric study. So this study looked at over 250 patients and assessed seizure burden and how it related to neurologic outcome and neurologic decline, and they controlled for many different factors. And so what they found was that a seizure burden greater than 20% was associated with neurologic decline. And so that was kind of the cutoff that we are using now. And the way that's changed our clinical practice is we get a little bit more aggressive when that seizure burden crosses 20%, because then we're worried about the seizures themselves causing additional injury to an already stressed out brain. So back to this study, what this group did was they took 69 patients who had had superrefractory status epilepticus and then went on EEG. They had a neurophysiologist quantitate on the raw EEG the minutes of seizures. This is kind of our gold standard seizure burden for this cohort. They had 2 quantitative EEG experts and 2 novices who got a 1 hour teaching session go through the quantitative EEG on all these patients. And what's different from this study compared to the other ones that typically look at teaching seizure recognition in quantitative EEG for non-neurophysiologists was that they allowed a review of a lot of different Persyst trends, and they included the use of spike detection and being able to tell when it was less than 3 hertz or when there was rhythmic delta activity, which helped tip you towards that inner ictal on the ictal-interictal continuum. And so they found that 35 of the 69 patients had seizures. The qEEG experts identified patients with seizures 80% of the time. Novices identified 100% of them, but that was because they said everyone had seizures in this whole cohort, when it was really only about half. So excellent sensitivity, poor specificity. And this is the part that I think is most important. The novices estimated about 6,000 minutes of seizures, which is double what there was. And so that was less helpful, but the qEEG experts had about 3,000 minutes of seizure burden identified, which is really close to what it actually was. And that seizure burden is really what's the most important for these patients for the reasons I went over. And so the fact that quantitative EEG can reasonably approximate seizure burden could really be a game changer in review of these EEGs that take a lot of time. I'll end with these macroperiodic oscillations for this ictal emergencies section. This is an exciting rhythm that has recently been described and is still under investigation. So this is a 10-month-old who was on ECMO and had right watershed injury, and her EEG was quite suppressed on the right hemisphere, and she was having frequent seizures out of that hemisphere. So these are her seizures. Her quantitative EEG picked them up beautifully. You can see these flame-like seizures over the right hemisphere. The asymmetry spectrogram shows when there's more power on the right during a seizure. The suppression ratio, again, she was pretty suppressed anytime she wasn't seizing, so it would be high. And then you have this kind of nice mirror image of her coming out of suppression when she had a seizure. And if you take a step back, you kind of notice this really regular oscillatory pattern to her seizure frequency, with them happening every few minutes. So Dr. Reg Guerrero and his colleagues at St. Louis Children's Hospital also noticed this pattern. So they, in 2021, published their findings for this pattern, which they termed macroperiodic oscillations. And for the first study, they labeled it as a purely visual pattern on quantitative EEG that wasn't visible on the raw EEG, if you look at kind of the peak and trough raw EEG during these oscillations, but you really had to view it on a condensed view to see these regular periodic oscillatory patterns on CDSA or FFT spectrogram. So they looked at more than 500 children who had come through their ICU and had EEGs and found macroperiodic oscillations in 7%. The peak time was about 4 minutes. It was most common in very young children, in the neonatal age range. And they tended to occur within 12 hours of seizure onset or in the midst of seizures. 100% of those who had macroperiodic oscillations had seizures, compared to the non-MO group, where only about a fifth of them did. And the MOs went away when seizures were finally controlled. So this is just an example with the dashed lines noting the macroperiodic oscillations. Arrows are the seizures. You have them happening before the seizure. You have them happening during seizures. And then this just came out this year. They created a way to calculate the strength of macroperiodic oscillations. And they ended up using the envelope trend for this, and compared the envelope trend to regular sinusoid. And to quantify the strength of the macroperiodic oscillations, they use Pearson's coefficient to correlate it with the sinusoid. And so a strong correlation, or a strong MO would have a strong correlation, and it would have low entropy. So they created this index for strength of macroperiodic oscillations. Interestingly, it did not correlate with seizures, but it did correlate with worse outcomes having strong macroperiodic oscillations. They had one patient who had an ICP monitor in, and they did find a similar oscillatory pattern in the ICP, intracranial pressure. And so that could be a hint as to kind of where these rhythms are generated from, but more work is needed. But the way I've been using them, and again, this is not really validated in any way, I find them really helpful in refractory seizures in young kids. So this is a 16-month-old who presented with vomiting, altered mental status, and new onset seizures. This was her MRI, which shows severe cytotoxic edema throughout most of her brain, especially the cortical, subcortical areas. She ended up being diagnosed with TANGO2, which is transport and Golgi organization protein 2 homolog, which can present with a really severe metabolic decompensation that can affect the brain and other organ systems. And so she had super refractory status. She was on a pentobarb infusion. We got her off of that. And this was her background for many, many days after that. And this is that ictal interictal continuum. A lot of periodic discharges, some evolution within them. During these times, she would have some clinical seizures, she would have some electrographic seizures, but it was a really hard EEG to read. But if you look at the peak envelope during this time, you get this oscillatory pattern. You can see it on the asymmetry spectrogram as well. So she was having macroperiodic oscillations during these times of really abnormal EEG. So if we zoom in on her peak envelope trends, here's her macroperiodic oscillations. And again, she was having seizures when these got really bad too. And so we were trying to figure out which of her medicines, and she was on a lot, was the most helpful in treating her seizures. And so what I like to do is I take this 24-hour view, and then I just plot out and color code the medicines. And so these are all the medicines she got. And as you can see, the macroperiodic oscillations and seizure detection and clinical seizure did start to get better consistently after this purple arrow, which was the lorazepam or benzodiazepine. And this was just another day showing her macroperiodic oscillations on the FFT spectrogram, zooming out to 16 hours and plotting her meds. Again, it's really after these, the benzodiazepine, the lorazepam, that things would get better and she would clinically get better also. So this helped us know that that GABAergic mechanism was probably the way to go for her. This was a case sent to me by Dr. Raquel Ferris-Moeller at Medical College of Wisconsin, a 3-month-old with 5 days of upper respiratory symptoms, severe dehydration, and encephalopathy. EEG was initiated, and her initial quantitative EEG showed encephalopathy, but there's some state changes, no seizures. On day 1, Dr. Ferris-Moeller started to notice these oscillations and was wondering, what are these? And they are macroperiodic oscillations. Shortly after those started, she started having clinical seizures. So these are marking her seizures. She was treated with multiple medicines, eventually giving phenobarbital and doubling the midazolam infusion, resolved the seizures, and the macroperiodic oscillations went away. She did well for the next 24 hours, but you can see these oscillations start to come back. And then with that, looking at a more condensed view, you have your MOs, seizures recur, Phosphenetone was given, you can see this really drastic change in that oscillatory pattern and in the seizures. So this sodium channel activity worked very well. And this is the pattern of watershed injury that she had. Okay, so we're going to move on to different patterns of encephalopathy. These are the different examples that I want to go through. It's a long list, and I'll try and go quickly for the sake of time. So we'll start with neonatal hypoxic ischemic encephalopathy. There are a lot of different background categorization systems for neonatal HIE. This is one example of what the raw EEG does, starting with our most normal, a continuous neonatal background, to our most abnormal, which is just suppression. And why do we care about background? Well, background helps us predict neurodevelopmental outcome. And it is actually the most predictive feature of whether or not a baby with HIE is going to have seizures. If they have a more severely abnormal background, the more likely they're going to seize. So this is just looking at AEG. We have our normal EEG background, similar to the example I showed, where you have a wider band during quiet sleep and tightening up during wakefulness and active sleep, and you can see nice state changes. In a moderately abnormal background, the amplitude minimum is lower consistently, but you still get hints of state cycling. And then for severely suppressed abnormal background, it's all really low amplitude with just intermittent bursts of activity. So this is kind of our quantitative EEG grading of neonatal background. AEG background in the first 3 hours can help predict poor outcome with an 85% sensitivity. Seizure detection sensitivity is not quite as good. It can be less than 50%, and it's really user dependent and location dependent, especially with our traditional AEG electrode array. If you have a seizure over in the frontal region, it's less likely to pick it up. And then there's a lot of confounders like therapeutic hypothermia and the medicines we give that can impact the amplitude of the EEG. So let's think about gradations of encephalopathy for other ages, and I'll kind of go from worst to best case scenario. This is an 11-year-old after cardiac arrest who just had profound suppression. On your FFT spectrogram, that's going to be just all dark, cool colors. This teal band is likely artifact. Burst suppression has its own pattern. So on the FFT spectrogram, during the suppression periods, you get just kind of a blackout of color because you don't really have any frequency power. And then during the bursts, you get a sudden increase in your spectrogram color. And this is, I think of as a comb tooth pattern for burst suppression. So if you have someone post-arrest that you put them on EEG and you see this pattern at bedside, you know that's a pretty severe background. The AEG and also reflects this kind of comb tooth pattern, and then the suppression ratio is really high during burst suppression, of course. This is an example of just kind of a broadband, monotonous quantitative EEG with just a lot of slow delta. That delta band is really intense, not a lot of variability to the background. This is a much better scenario, an 8-month-old after cardiac arrest. This is her having sleep spindles. And for those who don't read a lot of baby EEGs, sleep spindles in babies are allowed to be asynchronous as long as they're symmetric. And you can see them really nicely on the quantitative EEG in this beautiful little beta band here, spindling from each hemisphere. So that's really reassuring. There's a nice publication that has shown that sleep spindles are associated with good outcome after pediatric cardiac arrest. So this is something I love to see. This is her during sedated wakefulness during this part of the graph. So if we look at our 2-hour trend, we can see, oh yeah, she has some really nice state cycling with N2 sleep and wakefulness. You can zoom out even further to an 8-hour time scale and see really nice state cycling. So that's something reassuring. I have one adult example. So this is a 28-year-old who got intrathecal chemotherapy and was encephalopathic, so went on EEG to screen for seizures. This is her while she's asleep, and this is her alpha-delta ratio trend. And so at the peak of this trend, she has a fair amount of alpha, a few delta slow waves. So let's go to the trough. And this is a very common encephalopathic arousal pattern in bigger children and adults. You get high amplitude bifrontal rhythmic delta activity, and that really increases the delta power and tanks your alpha delta ratio. You can see on the FFT spectrogram, she had a period of sleep, a period of wakefulness, sleep, wakefulness in this 1-hour period. This is just one more example of asymmetric sleep architecture in the ICU and how it correlates with pathology. This is an 18-year-old with altered mental status, and you can see this state, things look fairly symmetric. Left hemisphere has a little more power at the low frequencies. And then during this state, there's some asymmetry going on. So let's look at this first state. It's an encephalopathic slow background. And then this state where you get this asymmetry coming through, what it's picking up is asymmetric sleep spindles. And so on the right hemisphere in red, you have normal frequency of sleep spindles in the beta range. But on the left hemisphere, it's slower and you get this delta coming through and it's more alpha frequency. And that's because there's a left thalamic tumor. So this is impacting the thalamocortical connection, slowing down your spindles on the left, but they're still present. And then the ones on the right are normal. There's been one publication in recent years looking at quantitative EEG after pediatric cardiac arrest. This was from the Children's Hospital of Philadelphia. 87 children prospectively studied on EEG after arrest, divided by good and bad outcome by the pediatric cerebral performance category score. And what they found, especially on early EEG, having more gamma, delta, beta power of those specific frequencies was associated with better outcome. This is data that we're preparing. The manuscript is in preparation. We have a group of more than 250 children after arrest from multiple centers, and we divided them similarly by PC score after cardiac arrest. First, we looked at different degrees of suppression ratio in their post-arrest EEG in the first 24 hours. And if you bin them by suppression ratio, you can see a suppression ratio above 10% has a pretty poor outcome, but it's these patients where the suppression ratio is 10% or less, that there's a lot of variability. And if we can do better at predicting outcome using other quantitative EEG features, that could be really helpful. So this was using a random forest model to weight the importance of these different features, clinical and quantitative EEG features, in terms of outcome. And we found, again, not having sleep spindles was associated with an unfavorable outcome. Having a low beta power and having a high suppression ratio were also associated with poor outcome. And if you combine these 5 features, you get an area under the receiver operator curve of 0.95. And again, that's just in the first 24 hours of EEG. So a pretty strong predictive value for these features. I'll do a quick dive into congenital heart disease and this brain-heart connection that we all know and love. A little detour on historic precedents. The original AEG was the cerebral function monitor, where they did a lot of work on it in the 60s and 70s after cardiac bypass surgery and looking at post-arrest cases. So this was a case series of post-arrest cases, and this looks like that neonatal severe background that I told you about. This was an adult comatose patient who was really severely comatose and just had really low amplitudes. This was a patient 3 days after arrest who had another arrest on EEG, and you can see the drop in her amplitudes as she's arresting. And then this was a patient who had a barbiturate overdose and started to metabolize it out, and cerebral function improved. Those are her amplitudes improving there. So this was after cardiac surgery, noticing that as mean arterial pressure dipped, the cerebral function monitor declined in amplitude, and then it improved when they improved blood pressure. Looking at effect of the anesthetic and temperature, and then they found that classic arch appearance in seizures on some of these patients too. So going back to the patient population that I'm more used to, we monitor our congenital heart disease patients who are high risk after surgery if they are neonate. And so we looked at a little over 100 patients and divided them by neurologic injury, which was defined as seizure versus radiographic injury, versus those who didn't have injury, and looked to see if there's any quantitative EEG trends that could help us predict which group they were going to fall into. This is showing the theta power in the central regions. For the black squares are those who didn't have injury, the gray squares are those who did. And we found that from onset of EEG, which was typically 10 hours after surgery, they really separated out. And so this is a population, if there's lower theta power, that might be a patient you watch a little more closely and really trend their exams and things like that. This is not a quantitative EEG study, but it kind of frames the next few examples I'll give. This was also the congenital heart disease population from the Children's Hospital of Philadelphia, where they recorded in 22 subjects cardiac arrest on EEG, and they looked at the EEG background to see if it changed just before the arrest or at different time points. And they found that there was a change in the EEG background leading up to the arrest. So here's an example of this happening in just a really transient way. And this is kind of, I want to think about one of the most important principles in ICU EEG. And you'll see this in a lot of lectures about quantitative EEG in the ICU. And it basically describes what we know happens to the EEG as cerebral blood flow decreases. So the first thing is that you lose fast alpha frequencies, then you gain more theta, then you lose theta and get more delta, then you lose delta, and then you get suppressed once you've crossed that infarct threshold. On quantitative EEG, that looks exactly as you would expect. You lose your fast frequencies, you get more theta, and then you get more delta. So this is an 8-month-old with congenital heart disease undergoing mediastinal expiration at bedside. This is the EEG at the start. You can see on the second half of the page, you've lost a lot of fast frequencies and there's a lot of high amplitude delta slowing. Then you get even more simplified background and then suppression. So then I look at the quantitative EEG and see if it picked up this change, and absolutely it did. You see just a blackout of color during that period of suppression, amplitudes tank, suppression ratio goes up. And if you plot it out with the vital signs, these all correlated with dips in the mean arterial pressure. So let's see, these were just transient. The baby recovered beautifully. I want to kind of show examples of this happening over hours instead of just a few seconds using these principles. So I'll start with just two cases of focusing on one hemisphere. And the cases involve injury to one hemisphere that led to progressive cerebral edema and the need for decompressive hemicraniectomy. And the purpose of hemicraniectomy is to relieve pressure. Yes, we're trying to save this penumbral tissue, but we're also really trying to save this hemisphere that wasn't injured. And if this hemisphere is starting to show signs of distress and decreased perfusion on EEG, that's a sign that you might be needing to intervene. So I'll show you some examples. This was a 3-year-old who presented with fever and right hemispheric ischemia, pretty much to the whole hemisphere, and this progressed to significant edema and midline shift. This was his EEG. As expected, the right hemisphere is profoundly suppressed, but the left hemisphere has a lot of mixed in frequencies. He started to have clinical changes and electrographic changes. And so what you can see towards the end of this EEG is that he was starting to have periods of attenuation over that left hemisphere. And when we look at his FFT spectrogram for the left hemisphere, you start to see a decline in amplitudes. And that's a sign, along with the raw EEG, of a hemisphere under distress. And this was just before he went for his decompressive hemicraniectomy. This is an 11-year-old with a large right MCA infarct that swelled and swelled and swelled. And he also went for decompressive hemicraniectomy. Similar to our last patient, that right hemisphere is suppressed. The suppression ratio picks up that right hemisphere expression really nicely in red. And the left hemisphere had a nice mixture of frequencies. Our asymmetry spectrogram picked up that asymmetry perfectly. Amplitudes were different between the hemispheres, of course. And then this was how his EEG progressed as you start to see the left hemisphere suppression ratio increase. You have drop out of those faster frequencies, a lot more of this simple 1 hertz, 0.5 hertz delta. And towards the end, it's even more simplified, lower amplitude. So it was really this increase in the suppression of the left hemisphere, the unaffected hemisphere, that got me really worried. And he also had clinical changes and radiographic changes. So now we're going to go to the whole brain, both hemispheres. Dr. Sansevier nicely reviewed the publication that he authored about recording increased ICP on quantitative EEG. And what he found with 13 patients was that there was a rise in suppression ratio, an average of more than 3 hours before there was clinical or radiographic changes confirmed, which is type 2. This was an adult publication, also showing that suppression ratio going up during herniation. And what I'm going to try and convince you of is that in a lot of these patterns, we also see a dropout of fast frequencies happening hours before that suppression ratio goes up. So this is a 10-year-old with metastatic tumor to the right hemisphere. You see right hemisphere attenuation. Left hemisphere is also slow, but it's asymmetric. This is his recording at the start of the evening. And then we see the right hemisphere becomes suppressed. The left hemisphere loses complexity, starts to have periods of attenuation, and then both hemispheres become suppressed. And what we see is the suppression ratio going up a couple hours before complete herniation. You have a heralding seizure here, which probably increases pressure a little bit too. The left hemisphere suppression ratio comes up a little bit later, but here is where I think you start to see that decline in your faster alpha frequencies on your FFT spectrogram. This is an 8-year-old with diffuse cytotoxic edema and altered mental status. This is his initial EEG. His imaging progressed to more and more edema. You can see the ventricles getting tighter, loss of sulcation. This is how his EEG progressed, with some heart rate irregularity noted, increase in delta activity, loss of fast frequencies, periods of attenuation and simplification of the EEG. He had a right posterior seizure, and then after that was profoundly suppressed. So we have our heralding seizure. We have the suppression ratio that starts to go up a couple hours before. We had a new asymmetry where the left hemisphere wasn't perfusing as well as the right for whatever reason. But again, I think it's this initial drop in the faster alpha frequencies, and you can even see a decline in amplitude on your AEG that mark this initial decline. The alpha delta ratio picked it up nicely as well, as you're losing alpha and getting more delta. You can correlate it with other vital signs. This is heart rate in purple, so you can see heart rate declining during this time, and blood pressure starting to go up, which is 2 over 3 Cushing's triad. I'm going to skip this for the sake of time. So I want to end on a happier note in the last few minutes, just to talk about patterns of global improvement and ways that I can find quantitative EEG really reassuring. This is just a very simple example. 18-year-old with a bupropion overdose. That medicine can cause a severe coma, burst suppression background, and loss of brainstem reflexes, which can be really scary, but if supported through the toxic ingestion, these patients can make a full recovery, and this patient did. So you can see this comb tooth pattern of burst suppression at the start of the EEG, and then over a few hours, it starts to become more and more continuous. Your suppression ratio drops out, and she made a full recovery. This was a 9-year-old with acute liver failure and hepatic encephalopathy. This was her first hour of EEG. It's a encephalopathic EEG. It's too slow, but you have some admixed data with the delta. But this is 12 hours later, really concerning for worsening cerebral edema and dysfunction, these periods of attenuation, oversimplified bursts. So she was treated with optimal medical management of her ICP, including targeted temperature management, pentobarbital infusion to decrease metabolic demand. She got a liver and came back from the OR. And when she came back from the OR, for whatever reason, the pentobarbital was affecting her clinical exam more so than her EEG, such that she was low tone, unreactive. Her pupils were not responding, and we were really worried, but we put her on EEG, and we were able to reassure the surgeons and most importantly her parents that yes, she was very much in there. And over time, this is postoperative hour 3, I'll go to postop hour 9, you can see an improvement in her FFT spectrogram, gaining back more and more frequencies, including the faster ones. It's a more complex admixture here on her FFT spectrogram. Her amplitudes increased, her suppression ratio went away, and she also made a full recovery. Last example, this is an 8-year-old with ALL. He had CAR-T therapy to treat his relapse, and he developed cytokine release syndrome and neurotoxicity. And this can result in confusion, aphasia, and it can cause malignant cerebral edema. And so he was starting to show signs of neurotoxicity by day 7. And he was treated with methylprednisolone, anakinra, continued to worsen. CT showed diffuse edema. He was treated with targeted temperature management. We tried to suppress his brain activity with midazolam to decrease metabolic demand. Didn't work, so we did pentobarbital. I'll just walk you through his EEGs. So this was day 4 when he was pretty much at his baseline doing well. He has a nice posterior dominant rhythm, good mixture of frequencies. You have some delta, you have some alpha, theta, you have some beta. When he goes to sleep, he gets sleep spindles, which again, we really love to see. This is day 7 when his clinical exam was worsening, and it's a much more encephalopathic EEG with a lot of high amplitude delta and loss of that nice anterior to posterior gradient. If you compare the spectrograms and just kind of visually look at these degrees of encephalopathy, you have nice state cycling here, and this is our broadband monotonous, kind of just a lot of delta power with a little bit of admix fast. This was him as he was getting progressively worse, and then that correlated with cerebral edema on his CT. His alpha delta ratio started to go down as you're losing fast frequencies and getting more slow frequencies. So we suppressed him. There were a few hiccups coming out of pentobarbital, as there sometimes are, but this is him as he is clearing the pentobarbital, started with burst suppression, then got more continuous. We have our comb tooth pattern resolving, getting more and more continuous through the day, suppression going down. He had a long stay on rehab and a long recovery, but he actually did fantastic. So in summary, we are using quantitative EEG more and more in our pediatric ICUs, and the field is really ripe for standardization, research, and improving education of non-neurophysiologists as well. I hope I've showed you ways that quantitative EEG is helpful in managing ictal emergencies, from things like determining drug efficacy and mechanisms that might help your patients, titrating to burst suppression, and this really interesting entity of macroperiodic oscillations. And then you can use quantitative EEG for background assessment as well, different gradations of encephalopathy, detection of focal or hemispheric injury or dysfunction, global decline, and then global improvement. Now I will take any questions if there are any.
Wow, what a fantastic talk. Thank you. That was really, it was fast-paced and really interesting the whole time. Thank you so much. We had one question come in, and I'm sure we'll have a lot more. I actually had a quick question for you. In one of your examples of the patient that had a global decline, you talked about how the first thing that you see is the loss of the fast frequency, and then you have the other things. I think my question would be, given that, what would you do differently at bedside when you see that loss of fast frequency?
Yeah, and I think that's kind of the key question, is first recognizing it, and then what are you going to do to change your patient care? And for a lot of these examples, if it's global cerebral edema, things like an aggressive decompressive craniectomy are not going to help, and you just have to rely on ICP management, like high intracranial pressure management, and that's things like hyperosmolar therapy, temperature control, and sedation to decrease metabolic demand. And so those are things we employed with a lot of these patients. And I also want to emphasize, if you're seeing that kind of pattern at bedside for a patient who's at risk for worsening cerebral edema, the exam is so important. So going to bedside, examining the patient, seeing if they have a decline or if it's just related to maybe they got more sedation at that time, or and then looking at your vital signs, because those can also give you clues too of that pressure gradient.
So heightened vigilance on monitoring, basically.
Definitely.
Okay, yeah, that makes sense. Thank you. Okay, and then on to some of the questions that we have. Dr. Leitinger asks, do macroperiodic oscillations differ from cyclic alternating patterns?
I had slides about this and I took it away. And one of them was, are these CAPE or cyclic alternating patterns of encephalopathy? I don't think so, but again, we're really not sure what these are, in part because the time scale is a little bit different. Something that has also been proposed, I can't remember the acronym, but there's some talk that maybe these represent something like infraslow waves, which we see in adults after cardiac arrest. It could be associated with poor outcome. But I think we don't know, and it does seem to affect younger kids more. So it seems like it might be a pediatric specific thing. Although if you look in some of the refractory status epilepticus literature in adults with quantitative EEGs published, you can see these oscillations sometimes. And so I don't know. There's with that second study that the group put out showing, at least in one patient, a correlation with ICP and heart rate variability, that might suggest there's some role of autoregulation in these oscillations. And I don't know if that's a peripheral mechanism that oscillates at that speed, or if it's a central, like brainstem autonomic mechanism. We don't know, but it's really exciting.
That is interesting. I also had that question of whether
Mhm.
MOs are specific to pediatric or if they're cross population. So thanks for answering that as well. Okay. Julia Henry asks, how would you respond to the appearance of MOs? Would you ever try preemptive treatment of seizures?
So because we still don't know exactly what these mean and represent, the effect it has on me is when I see them emerge, especially in a patient who's already had seizures, is I get more vigilant. I get similar to the ICP trends. It just means I'm going to check that EEG quite a lot more and treat seizures when they come about. And I get a little relieved when the MOs go away, but that's purely anecdotal.
Oh, that's so interesting. Okay, one more question. I think I'm probably going to say this name incorrectly, but Chon Pivot Tripong asks, what did you find from quantitative EEG before cardiac arrest happens, before the vital signs change that significantly?
So we haven't actually looked at that in our kind of research group. So I don't have an answer to that. I think it's something that a lot of groups want to explore, and combining our efforts will be helpful. I would suspect that if the kind of systemic, if the patient's body is declining, like lower blood pressures, worsening heart rate, things like that, you're going to see that similar pattern of loss of complexity on the EEG, possibly loss of amplitudes in the babies, but that's also still hypothetical.
Okay, Taylor Nickerson says, thank you so much for the amazing talk. I was curious how you envision best practice of more routinely implementing quantitative EEG for indications other than seizure detection in the PICU. Specifically, do you think it's feasible for all intensivists to learn quantitative EEG as a point of care tool, or do you think it would require a neurointensivist consulting service in addition to neurology reviewing the continuous EEG tracing in full?
So I am really excited about bringing this to the bedside and making it a point of care tool. And I kind of like that parallel to things like transcranial Doppler ultrasound and making it a bedside tool. The role I see it is, teaching bedside providers, intensivists, nurses, fellows, residents, how to interpret it and what these trends mean, what you can and can't detect using quantitative EEG. But I even, as a neurointensivist, I still fall back on the raw EEG, and I always confirm everything on the raw EEG. And that's for seizures and background decline, anything focal, things like that. And so I hope to create some online learning modules where people can, and that's something the PedQuest group is going to try and do, to create teaching modules for these different patterns that we can see at bedside for anyone without a neurophysiology background to be able to learn. But I do think it's important to always kind of bring it back to the raw EEG and confirm it with an epileptologist or neurophysiologist.
Yep, that makes a lot of sense. Great, thank you. We don't have any more questions at this moment. And so I'll take the opportunity just to stop here because I do know that you're on service this week, so we want to let you get to your patients. I want to thank you so much for a great talk, and just remind everyone of your transition to the University of Michigan as Director of the Pediatric Neurocritical Care and Inpatient Neurology Program. So stay tuned for your work at that center, and we really look forward to seeing more of you. So thank you very much.
Thank you. I'm going to head out.
Bye.
Thank you so much.
Okay, thank you so much. Bye-bye.